So Katerina Pavenski is the head of the Division of Transfusion Medicine, clinical hematologist at St. Mike's Hospital in Toronto. She's an associate professor in the Department of Lab Medicine, Pathobiology at U of T. And she's a busy physician scientist. Yes, she is. And I really met her, I guess, years ago at complement-related meetings, I'm sure, where she's just a whiz at it. And I've always been really a fan. And she does fantastic work. And I know that she is extraordinarily valued at St. Mike's because I have some inner influences there. So it's my pleasure. I'm glad she finally made it here because we know how to get her here for a little bit. All right, so Katerina, you're on.
So I feel very privileged to be here, so thank you for inviting me, and I feel privileged talking about my favorite disease in the world, which happens to be TTP. I do have some relevant disclosures. I do clinical trials, industry-sponsored clinical trials, and currently I am involved in a trial that is studying a novel therapeutic in TTP. And what I'm hoping to do in a very, very short period of time is describe diagnostic approach. I do want to spend a little bit more time on actual ADAMTS13 and what it means. Very briefly mention acute and chronic complications, and then spend a chunk talking about therapeutic options that are at least in development. So it's interesting, it's been exactly 100 years this year since the first case of TTP was described. And I do encourage you, if you have a chance, to read this paper that goes over the history of TTP and all of the important discoveries, from the description of the case to recognition that the answer is in the plasma, to finally recognition of ADAMTS13 as a causative agent, cloning ADAMTS13, a very important Canadian contribution showing, and that's the Gale Rock paper from '91, showing that plasmapheresis saves lives, all the way to the development of the first purpose-made medication for this, which is caplacizumab. So very exciting, 100 years. It only took us about 100 years to figure it out, and we're still working on it. So when TTP should be suspected, it's one of those things that medical trainees indoctrinated to fear this question, especially on their licensing exams, because this is one diagnosis you do not want to miss. You do not want to miss this patient and send them home. Patients come in with low platelet count. They come in with hemolytic anemia, fragments on the blood film. So usually red cells are these perfect donuts with a central pallor, but when you see these jagged edges that look like helmet cells, like helmets, schistocytes, that's fragmentation hemolysis. And of course, these patients exhibit damage to key organs. So heart, brain, and kidneys are the most frequently hit. What is the epidemiology of this condition? It is a very rare disease. So I tell my patients it's 2 to 3 per million population. There is a disproportionate involvement of women over men, about 2 to 3 times more frequent in females. And it usually hits women of reproductive age, so usually in the 30s to 40s, although I certainly am aware of pediatric cases and very, very late geriatric cases as well. And the causative agent of this disease is ADAMTS13 deficiency. And when I say deficiency, most studies define it as ADAMTS13 activity below 10%. Now, not a scientist. I am a clinician investigator, but I'm not a scientist, but it has a very interesting pathophysiology, which, again, everyone learns in medical school without appreciating just how little we do actually understand. So we do know that it is deficiency of this enzyme, ADAMTS13. But we also know that you can live your entire life with undetectable ADAMTS13 and never get a disease. Never get thrombocytopenia, never get a stroke. In that regard, baboons, if they give them anti-ADAMTS13 antibody, they develop TTP. Mice need an extra hit, so we're more like mice than baboons. So, but basically the story is there is these very large von Willebrand factor multimers, and in the absence of ADAMTS13, they trap platelets, forming these rigid structures that you can actually see microscopically, that are like fishnets trapping these soft red cells, shredding them, hence the presentation of fragmentation, trapping the platelets, the platelet count is low, and this platelet-rich thrombi are what is occluding microvasculature, causing the damage to the organs and demise of the patient unless it's urgently treated. Now, yes, there is complement involved. And yes, there is somebody mentioned natosis, and somebody mentioned this and that, and the point is that we don't, beyond what I just said, the pathophysiology is way more complicated. So all the way to knowing that this condition is more likely to occur during the times of high shear stress, so pregnancy, infections. So milieu is really important. We know that it's more common if, to form an antibody if you have a certain HLA type or you're a certain ethnicity. Hormonal milieu plays a huge part. If you happen to be a female of reproductive age or a female who happens to be obese, your chances of getting this disease are substantially higher. And suffice it to say, we don't really understand everything that comes into play during this disease. The antibody, there are two types of TTP that we recognize. There is a congenital TTP. This is something that you're born with it. It's usually acquired in an autosomal recessive fashion. You have to have two alleles hit, and there are lots and lots of mutations that have been described. It happen to be private mutations most of the time. So unlike some other diseases like cystic fibrosis, where there is mutations that are common among a large group of people. In adults, the predominant version of the disease is autoimmune. And it's an IgG autoantibody that predominantly binds to cystine reach or spacer domain. That's what binds ADAMTS13, and that's what causes disease. Why? We don't know. So suffice it to say, ADAMTS13 activity is really fundamentally important. If you have low ADAMTS13 activity, you have the disease, and this is how we used this test in the past. Now we're also using it to confirm response, to see if further immunosuppression is necessary, but there are some other very, very interesting ways of using ADAMTS13. So for example, if you happen to be deficient in ADAMTS13 in remission from TTP, your chances of developing acute TTP episode are very high compared to those who have normal activity. What also is interesting is low ADAMTS13, and when I say low, I mean below 60 to 70%, which by all accounts is normal activity. You're at higher risk of stroke, and you're at higher risk of stroke even if you don't develop TTP, and there are some also interesting population studies in people who do not have TTP, but who have lower levels of ADAMTS13 that show this association. So I am going to talk more about therapeutics, but I do want to point out that having that access to this test in remission is fundamentally important, because if my patients have ADAMTS13 of 60% or higher, I can tell them the chance of you imminently relapsing are very low. However, if you're less than 20%, the chances are very high, and we should proceed with prophylactic therapy, usually with immunosuppression. And if you're in between, we watch you very carefully, because the situation can change very quickly. In order to demonstrate that this is an autoimmune version of the disease versus congenital, we employ autoantibody or inhibitor testing. And that can tell us that if the antibody is present, you can be reasonably convinced that this is autoimmune version. If the antibody is absent, with proper follow-up and additional investigations, you can conjecture that your patient may actually have congenital version. ADAMTS13 antigen is rarely used, but has been shown, and primarily because it's not really available in Canada, but it has been associated with increased risk of mortality. Now, the last bit on the slide is by far the most interesting and fairly recent development. So we know if a person is healthy, their ADAMTS13 is closed. When a person has TTP, ADAMTS13 circulates open. It also is linked to the amount of ADAMTS13 in your body. So if you are deficient in ADAMTS13, you circulate in the open conformation. So this test is now being touted as a test to predict relapse. So this is like, if you follow your patients and they're always more than 60%, you have no idea when they're going to relapse. And it's actually quite stressful to the patient because something can just happen and they can just get really, really sick. So you can offer them this test, and if you see that it's open confirmation, there is a great likelihood that the next time you test them, their ADAMTS13 will drop, and the next time you test them, they're going to be developing TTP. So interesting, more data to come, but this is one of the newer things that have come out recently. Only done now in a few labs and only in Europe so far. Okay, so I promised I'm going to talk very, very quickly about how bad this disease is. So when the person first comes in, and this is why you're never supposed to miss this case, is that the moment you walk in with TTP, 50% will have heart involvement, about 50% will have kidney involvement, 50% will have brain involvement. If you don't do anything and don't institute treatment, death is imminent. So more than 90% will proceed, will not be salvageable. And it happens very quickly. So over a period of a couple of days, so some of the oldest studies before we even had access to plasmapheresis, for example, these patients died over a period of days. So it's absolutely catastrophic, very important to diagnose it and treat it. Again, many of you who've been in hematology for years were also taught that TTP is an acute disease, you fix it, you can discharge the patient, you can forget about them, they've passed it. Now I recognize this is a chronic disease, and one of the chronic manifestations is relapse. So before the advent of rituximab, I'm going to speak about rituximab in a second, we used to tell patients that your highest risk of relapse is within the first 2 years. By 8 years, the curve flattens out. You're not going to get it, most likely. Having said that, people can relapse 30 years later, but that's very, very, very unlikely. What rituximab has done, and you can see that in the bottom graph, and I don't know if I can point, probably not, but you can see the separation. So rituximab will delay the relapse, and it will also decrease the risk of relapse. So now we tell our patients, after you received rituximab, you probably have 2 to 3 years, and after 10 years, you can be reasonably assured that it's not going to come back. So that's how long I usually follow my patients following acute episode. There are many long-term complications. This is another reason why these patients should be watched very carefully. Many of these on the slide, but more importantly is neurocognitive events, as well as significant mental health problems. And again, in the past, we used to say, oh, it's PTSD because it's a very stressful condition happening to a healthy person, and it's just difficulty, coming to grips with this. Now we're understanding that there might be actually a physiological explanation to it, and we're involved with some pretty interesting studies about blood-brain barrier leakage that correlate with neurocognitive deficits. So that could actually be the explanation for all of the anxiety, depression, and as well as cognitive abnormalities, which, by the way, are progressive. Despite the fact that you may not relapse, the cognitive abnormalities tend to progress in this patient population. Very important because we're dealing with younger people in the prime of their lives. So how do we diagnose and treat TTP? Recently, there have been the first ever multinational evidence-based guidelines published by ISTH. They're freely available from their website, and they talk about the diagnosis and the management. And the way they're organized is that everything that had reasonable evidence became part of the clinical guidelines. Everything that we know to be correct but just didn't have enough evidence ended up in the good practice statements. So anyone who manages TTP, I encourage you to review these. And basically the treatment, there are 3 pillars to treatment. The first thing you want to do is give ADAMTS13 back because that's the most immediate problem. The second thing, you want to suppress immune system from producing more IgG autoantibodies. They're going to take out your ADAMTS13 and allow this disease to continue. And the last thing is to inhibit from platelets and VWF coming together, because the moment they come together, that's how the microthrombi form, and that's how people develop the catastrophic organ complications that they do. So when do you suspect TTP? It's a clinical diagnosis, but people have spent a lot of time trying to figure out some scores. We already saw the 4T scores from Isaac, so here's a score that was developed actually in the United States, and it's available on MedCalc. In fact, most of my trainees have it on their smartphones, so they can quickly tally up and decide what is the probability. And once you tally up this, it will give you a probability that your patient has severe ADAMTS13 deficiency, or in other words, TTP. But I would say anything that is unexplained, thrombotic microangiopathy, fragmentation, hemolysis, unexplained with organ damage, should be treated as TTP because the risk of missing TTP is very high. This risk score, by the way, has been shown to underperform in geriatric patients and patients with other complex autoimmune conditions, so do not rely on the score. And basically what the guidelines tell you is as soon as you think that this is TTP, you're going to start corticosteroids and plasmapheresis. Once you confirm the diagnosis, you add other things. So what are those other things? So let's talk about those other things that you're going to be adding, because we know plasmapheresis has existed for many years. It's an established therapy. Steroids, the same thing, but what are some of the newer things? So the first one is, as I promised to say, is rituximab. It's an anti-CD20 monoclonal antibody, was developed to treat lymphoma and has had huge impact on treatment of benign or non-malignant autoimmune hematological conditions. And it doesn't matter in what dose you give, because you can give it in a smaller dose or higher dose. It doesn't matter when you give it, but it reduces mortality in these patients. And not only it reduces mortality, as I've shown you before from the other graph, it reduces the risk of relapse. It works so well that it has been shown to be profoundly cost-effective. So if you administer it during the initial presentation, you can achieve cost savings of $900,000, and that's American dollars. And why? It's because treating these patients is extraordinarily expensive. So rituximab is neither Health Canada approved for this indication, nor funded in any province for this indication. But it is absolutely life-saving, and in other countries is considered to be one of the most important immunosuppressive pillars of therapy. Okay, let's talk about caplacizumab. So that's another really exciting development. It's an anti-VWF antibody. It binds to A1 domain of VWF and thereby prevents platelets from binding. So this is the first therapy that was specifically developed for treatment of TTP. Do we have any evidence that this works? Absolutely. There have been 2 randomized controlled trials, both published in New England Journal of Medicine, and then Titan and Hercules, and then their combined analysis was subsequently published in Blood Advances. In addition to plasma exchange and steroids, caplacizumab reduces time to normalization of the platelet count, reduces refractoriness, reduces mortality, reduces thrombotic events. It also significantly reduces utilization of healthcare resources because you can get off plasma exchange faster, you can get out of the hospital faster. At the expense of bleeding, because you think about this, you block the interaction between VWF and platelets, the most significant side effect you can think of would be mucocutaneous bleeding. Now, we always know that performance in randomized controlled trials does not match necessarily performance in the real world. This has been translated to real world. Many countries have published their experience, essentially confirming what was found in the randomized controlled trials. The last of these is the CAPLA 500 project, which is not even, it's more like CAPLA 1000 project that essentially combined data from close to 1,000 patients from 10 countries, confirming that survival is better in those who receive caplacizumab as an adjunct therapy to plasmapheresis and immunosuppression. In fact, failure to achieve clinical response was 5 times less likely in the caplacizumab group as compared to the control group. So very, very effective. It also made us get together and change how we define remission. So now we talk about the TTP remission and the ADAM-TS13 remission, because it's not enough just to achieve TTP remission. You also have to achieve ADAM-TS13 remission to achieve long-term health. There's a lot of argument, because this drug is quite expensive, as you can imagine, as most drugs for rare diseases, whether absolutely every single person with TTP should get it. I'm not going to get into this argument. To me, one of the biggest values of this drug is that it can save patients who we previously felt to be unsalvageable. So what you can see here is a patient who's had TTP multiple times. She's coming in day 1. You can see her platelet count of 7. That's her plasma from plasmapheresis in the bag. You could see how brisk her hemolysis is. Day 9, that's after 9 days of plasma exchange and corticosteroids and rituximab, and there is absolutely no improvement. She is at this point intubated, seizing in the intensive care unit, and we're having end-of-life discussions with her family. Because our site was part of Hercules trial, at this point we asked the company for compassionate access. It was not approved in any country yet, and they advanced us the dose, and you can see an absolutely remarkable response. So for me, the biggest gift of this drug is to be able to save someone who we previously would have considered unsalvageable. Then the big question came up: if the main treatment of TTP is treating with plasma, what about Jehovah's Witnesses, those patients who actually object to plasma infusions? And until recently, there was not much we could offer them. And then this case report came out showing that, in fact, with immunosuppression and caplacizumab, so anti-VWF therapy and immunosuppression, you can actually successfully treat a patient. And this led to the study that is currently ongoing, and we're actively recruiting, called Mayari, which is a phase 3 open-label single-arm study. So this is for the first time giving immunosuppression and caplacizumab, no plasma exchange, challenging the standard of care, see if you can forego this treatment and achieve the same effects. And this is a frozen waterfall because caplacizumab has been approved by Health Canada, but both INESS and CADTH recommended against its reimbursement. It was challenged twice by the company and was rejected again. So right now this drug is available only through private insurance plans, but it's very, very difficult and only for outpatients. As you can imagine, this drug, the biggest value is when the patient is critically ill in the ICU, not when they've been discharged home, and there is no longer a compassionate access program in Canada. So, sad. I'm hoping that maybe if Mayari is positive, we can reopen this discussion, but for the time being, this is not the drug you're going to be using in your clinical life. Okay. One other very quick novel therapy that I'm going to talk about is recombinant ADAMTS13. So the protein was cloned for a long time. It took, for whatever reason, a very long time to bring it to market in any form. And studies for congenital TTP have been completed, both phase 1 and phase 3. And now there's an extension program. So great opportunity for congenital TTP. By the way, this drug is now available on compassionate access. So if you have congenital TTP patients you want to switch, it is possible in Canada. But the big question was, what if you give this drug to people with autoimmune TTP? Can you overwhelm the inhibitor the same way as you can overwhelm an inhibitor in, say, factor VIII with inhibitors, like hemophilia with inhibitors? And the answer is, in principle, the answer is yes. So there was this study, which is a phase 2 study. It's been completed. It still is not published. We're still meeting about how we're going to put these results into publication. And this study was not really designed to check efficacy. What it really is doing is showing is that you can achieve higher ADAMTS13 levels. So in other words, you can overwhelm the inhibitor, and the real study for efficacy is going to be taking place. In fact, the protocol for that study was written, and it is going to proceed in other countries, but Canada has been excluded from this discussion because Health Canada could not agree to a protocol. So, with that, I am going to stop because I already over my time, and I'm going to take questions. But I do want to say that 100 years we got some great achievements in this 100 years in TTP. And it was interesting because TTP was not an interesting disease for a long time, and now it is. And now that there is therapy both in ADAMTS13 and caplacizumab, all of a sudden the basic science has become very good about it. And if you actually track this literature, you'll see that every couple of months there is like this other great publication on pathophysiology. So it has generated new interest in it. I just hope that this great interest is going to lead to better therapeutic options in our patients. So thank you for your attention.
Thanks, Katerina. That was great. I have two questions, one about rituximab and the other one about ADAMTS13 recombinant. The rituximab shows a really nice durability and remission, and you said you follow the ADAM-TS13 and antibody. Does the remission sustained despite the fact that the antibody comes back?
So it's interesting. I don't usually test the antibody, and I'm sure some of my colleagues do. Part of it is cost of the test, and part of it that the strongest evidence is actually for ADAM-TS13 activity. So what I track is ADAM-TS13 activity. So, and how frequently, the gold standard in the world is to check ADAM-TS13 activity every 3 months. So all of you who are hematologists out here, I challenge you to go to your special coag lab and ask them to do that, and they're going to go into apoplectic shock. So it's expensive, and it's not something that has been really socialized in Canada. Mine is kind of like if somebody is low, I would follow them a little bit more closer. If someone is really good, more than 100%, I may follow them every couple of years for their ADAM-TS13, but I don't usually measure the antibody. But once the ADAM-TS13 drops, your antibody titer is definitely up.
That's good to know. The recombinant ADAM-TS13 therapy, I noticed that you said I think the assumption is that you overwhelm the antibody, but I noticed that you also, it's in combination with Plex, right? Plasma exchange, sorry.
So the study that I showed you, this guy, the phase 2 study. So when Mayari was being designed, when this study was being designed, no one was brave enough to go against that we're going to drop plasma exchange. Plasma exchange, since '91, was the standard of care. And many of us in the room felt very uncomfortable to just say, how are you going to convince all these hematologists to enroll patients where you're not going to offer the gold standard of care? So both the Hercules and Titan and this study were designed in addition to plasma exchange. And plasma exchange obviously brings in ADAM-TS13 with the plasma that you're infusing. That's the whole point. But what they were able to find in the study is that what you get with supplementing exogenous ADAM-TS13 on top of plasma during plasma exchange was so dramatically better that we assume that there will be a clinical benefit. So the study that is about to take place is going to be without plasma exchange.
So, I mean, amazing, but plasma exchange also depletes the antibody. So I'm wondering the balance between how much you're adding and how much you're depleting would be so informative to understand if you can remove plasma exchange and
so
only
this
use
is,
the
I think this is the most interesting question. So I am a plasmapheresis doc, so I do believe that plasmapheresis does play a role in removing the antibody, not just giving ADAM-TS13. We don't know if that's true or not. In fact, a lot of TTP scholars believe that the contribution of removing the antibody is very low, and the way you get at the antibody is you hammer with immunosuppression. Steroids, rituximab, that's why you have to give rituximab up front, because it takes, like everyone knows, it takes about 2 weeks to start working, so you have to give it as soon as faster. But I do believe that plasma exchange does contribute something. But belief is not science. So once we see these, like once I see the results of Mayari, once I see the result of this, then we can have an intelligent conversation. Does it actually do anything? Yes or no? So the last thing I'm going to say is, so in Titan, the very first trial, remember, how do we stop plasma exchange in TTP? When people reach a certain platelet count. Well, you give somebody caplacizumab, their platelet count is good by day 3, day 4. So we stop plasma exchange. And so it's not surprising that people will exacerbate because the antibody is still there. We still haven't done enough immunosuppression, not enough Plex. So I think we may find something similar here. So it's not so much that Plex contributes tremendously to the removal of antibodies, the fact that we need time for immunosuppressive agents to work. But again, we all could be wrong, and the only way to find out is to wait for the results of the study. I know Eileen had a question. Oh, there's.
Yeah. Okay. Yeah. Really good talk. I oversee the ADAM-TS13 testing here in Vancouver, and we use the Technozyme ELISA assay, which I think is used in Toronto as well.
Yep. That's what we used to.
And so a couple things. One is adding more samples actually kind of decreases the cost per test.
Yes, I'm well aware of that.
There's a gain of efficiency.
The wells on the plate.
Yeah, exactly. So that you do kind of get more bang for your buck if you run more samples. So to some degree, it's not the worst thing to run more samples. But the other thing I was going to say is our inhibitor assay, it's technically just recognizes antibodies that bind
Correct.
to MTS13.
It's not an inhibitor assay, even though it's called inhibitor assay.
Exactly. And so that's good in some ways because maybe you pick up antibodies that not only inhibit but also maybe clearance type antibodies. But in our hands, we found that it's not picking up all the antibodies. And that might be another reason why you find it more beneficial to monitor activity is it seems like for some patients, they have this clear immune behavior, but we're not picking up the antibody with the assay.
So I think it's a problem with the ELISA assays.
I do
so at the beginning, I was so excited, when somebody comes in and they have undetectable ADAMTS13, they clearly have TTP, and the antibody is negative. I'm like, oh my God, I get to diagnose congenital TTP, woohoo, right? And then the answer is no, they don't have congenital TTP. It's just our assay is not particularly good, and there are people who have low titer antibodies. We now know that. We now know that from all of these trials. Again, there's so much data from these trials that hasn't been published yet, but there are people who have low Bethesda units, high Bethesda units, right? So we start sending them to Centristine that does the proper inhibitor assay, the FRET assay, and we're like all of a sudden picking up all of these antibodies. So that ELISA inhibitor assay is not the best.
That's been my experience too. Yeah.
So I always tell my students now is that don't get too excited. Let's just see. Let's repeat it again. I would still give them rituximab because the overwhelming odds this is immune.
Yeah. Thanks.
Hi, I'm curious about the psychiatric symptoms seen in patients with TTP. I was wondering if you could speak more about the biochemical basis for this and if serotonin levels are affected.
So I don't know if anyone ever actually looked at serotonin levels. So first and foremost, I'm telling you, most of us were taught that TTP happens, it's acutely very bad, you fix them, you send them away, you send them back to the referring hematologist in the community center, they don't need to be followed, end of story. And I think somewhere around, I would say maybe 15 years ago, a few researchers really took it upon themselves. Actually, Oklahoma Registry was one of the first ones, et cetera, that start looking at it. And once one group has shown it, then the other group has shown it, and now it's been shown by a few European groups, quite a few American groups as well, that this is a thing. So the neuropsychiatric complications, everyone recognizes that they're there, but no one has done yet the research to identify what is the biology behind it. A lot of it, there is still an explanation, oh, this is because it was very stressful, it's adjustment disorder, et cetera, et cetera. Neurocognitive stuff is a little bit advanced in that way. So when people have neurocognitive complications, and it's a very specific part of your brain, and it's very specific, it's things like word finding difficulties, attention span, it's executive function. And it could be very, very inapparent until you actually subject this person to testing and realize that they're not doing well for their age and their level of education. The first thought was that it's because there's these microthrombi in the brain and you can't pick them up on CT, and if you only went with a more sensitive technique like MRI with thin slices, you can pick it up. But then we were finding that there are people who have very extensive things that still don't have those little tiny holes in their brain scans. And so one of my colleagues from London, Ontario, who also has a degree in physics, collaborated with a radiology department. They started looking at blood-brain barrier. And what they found, and they were literally fishing, they were looking at people who had stroke, Alzheimer's, depression, and whatever. And they found that in patients with TTP, there is profound disruption of a blood-brain barrier, and it doesn't normalize for months and months after recovery, and sometimes longer than that. They took it a step further and started correlating it with neuropsychiatric testing, and they actually found they were able to correlate this blood-brain barrier leakage to the neuropsychiatric findings. So I'm extrapolating, my opinion personally is that it's not just adjustment disorder. There is actually a bona fide biological basis for this. And the blood-brain barrier has been implicated in something like in depression, for example. So again, more to come. All of a sudden became a very interesting disorder, so there will be more research in this area, I'm sure.